Thank you, Kate. Well, thank you again for having me here, Kate, for inviting me, and congratulations to all of you for making it through the next to last session on a Sunday afternoon when y'all should be probably wanting to go home, right? So, who's treated patellofemoral pain before in this room? Yeah. Anybody not? Ever? Know what I'm talking about? Okay. It's pretty common, that's why I'm asking. Okay, so I don't have any incredibly revealing or earth-shattering evidence to show you that's going to solve the patellofemoral pain problem. But hopefully what we can do in the next 45 minutes to an hour is talk about maybe an approach, other things that I've thought of that you haven't or you've thought of that I haven't in terms of how do we approach these patients. And I'm going to shamelessly steal from Dr. Quinn yesterday in her food analogy. Being Italian, I have to change it to include the Italian heritage. So, you know, I think treating these individuals or a syndrome such as patellofemoral pain, it's like a recipe. There are no two recipes that are the same. In Italy, you know, you can go from one village to the next, literally half a mile, and the recipes are completely different. The dialect, almost the language, is completely different. So the spaghetti sauce is different from one house to the next. So I think for this, we have to kind of think in those same terms. What's the recipe for each patient that's going to work, or we hope is going to work? And it doesn't always come out, you know, sometimes the sauce isn't so good, and sometimes it's really good. So I think if we can think of those terms or have an open mind or think outside the box rather than a rigid set protocol, that's not going to work for this, as probably most of you in this room have experienced. The protocol stuff just doesn't help, does it? All the time. Sometimes it does, sometimes it doesn't. So what is patellofemoral pain syndrome? Whoever really thinks about that? Well, I don't know that anybody really knows because we've got about 16 different names for it. And whenever there's 16 different names for something, it always makes me wonder, do we really know what we're talking about or what we're describing? It's been called, I mean, this is just a short list of the terms that have been used to describe this syndrome. Retropatellar pain syndrome, chondromalacia, which we'll find out later, that's inaccurate to describe patellofemoral pain. Chondromalacia patella is a pathologic diagnosis, and I'll show you a picture of that later on. So we don't ever want to use that, although it still is very commonly utilized to describe the syndrome. It's called patellofemoral stress syndrome, patellar tracking dysfunction, runner's knee, lateral facet compression syndrome, and on and on and on. So things aren't always what they seem by the name, correct? So what is this? Anterior knee pain, one definition anyway, anterior knee pain involving the patella and retinaculum that excludes other intra-articular and peripatella pathology. That says to me, we really don't know. It's anterior knee pain. It's pain in the front. It might be coming from the patella. It might be coming from the retinaculum. I don't know that it's consistent in one patient to the next. A lot of people use it as a diagnosis of exclusion, and I think you always have to think of that. And we'll show some examples later on that just because they have anterior knee pain and they're a young adolescent and a female and have some risk factors does not automatically mean that they have patellofemoral pain. I think that needs to be in your differential, but you can't just jump to that conclusion. It is among the most common diagnoses in sports medicine. Nearly 10% of visits to orthopedic and musculoskeletal clinics involve patellofemoral knee pain or have that diagnosis. It does more commonly affect women, and we'll talk about some of the risk factors for that, which many of you probably already know, and it is most common in the second and third decades, typically in active adolescents and adults. So there is an international patellofemoral study group, which I didn't know about before. So they have some terms that they've tried to clarify this a little bit more thoroughly so that maybe there's some commonality in terms of terminology, and when we're talking to each other or referring patients between each other, that we have some understanding of what we're doing. Anterior knee pain is reserved for the patient not yet evaluated. So that's really a chief complaint on the schedule or the presenting complaint in the office. Patellofemoral pain syndrome is used when there's no identifiable cause of pain. Chondromalacia patella is actually a softening of patellar cartilage, so that is a pathologic diagnosis. Luxation or subluxation is complete or partial displacement from the trochlear groove. We've all seen patients that have either dislocated or are subluxing all the time. Incongruence or lacking of fit of the patella into that trochlear groove. excessive lateral stress syndrome, describing an abnormally tight lateral retinaculum causing lateral tilt and high stress on the lateral patella. So even the International Patellofemoral Study Group can't come up with a specific terminology or definition, if you will, for this diagnosis. So what's going on in the knee? What happens that creates this situation? Jenny McConnell, which many of you will probably know the name at least from McConnell taping. How many physical therapists in the room? Quite a few. So you're all familiar with what McConnell taping is. Can be a very, very useful tool. Describe the patella, and I really like this description, as a balance beam that adjusts the length, direction, and force of each of its arms, the quadriceps tendon and the patellar tendon, at different degrees of flexion. So as it goes through its range of motion, different forces and factors are operating to control the movement of that patella. Which right there tells you there's a lot that can go wrong, right? And when we talk about the bony anatomy, at about 10 to 20 degrees of flexion, the inferior patella comes in contact with the lateral femur, and the patella is very unstable at that point. So that's when a lot of that luxation and subluxation can occur. In full extension, the patella sits lateral to the trochlea, and then, of course, with help from other structures, can be even further lateral, and depending on the shape of the trochlea, which we'll look at, can affect that position as well. At the 30 to 90 degree flexion point, there's increasing contact within the trochlea, and there's more stability, so it's happier there. And the medial patellar facet contacts the trochlea at 135 degrees of flexion, so at full flexion. Does that all make sense? Yeah. I apologize if some of this is redundant or you've heard it before, but I'm just trying to put this all in a framework. So they have looked at describing patellofemoral joint reaction force. So okay, this is a hinge joint. That patella is supposed to move up and down the groove. What's the problem? Why is there a difficulty? So even though there's just that bony function that we described, there's also soft tissue factors and a resulting vector force that can create difficulty. And that vector force is likely quite different in one individual to the next. So the resultant vector force, and this is physics, sorry, is equal and opposite to the resultant of the quadriceps and patellar tendon tension. So you can see that it goes basically back towards the posterior aspect from the top of the patella. So it's that compression feeling, and that whenever you examine the patient, you can often aggravate their symptoms by pushing down. So that's that resultant force. That force increases with flexion, it increases with walking, going upstairs, squatting, jumping, and the more force that's put on it, the higher the stress and the joint reaction force. So then you have the soft tissue stabilizers of the patella. And I kind of like Jenny's description is there's sort of the ones on the top, the ones on the bottom, the ones lateral, the ones medial. So in the superior direction, you have the rectus femoris, the vastus intermedius, laterally, vastus lateralis, IT band, and the lateral retinaculum. Inferiorly, the patellar tendon, and then medially, the VMO and the medial retinaculum. So all of these are operating in a different way with different function at different points of flexion or extension through the knee while they're moving around. And I think we cannot eliminate or forget what Dr. McGinnis talked about for the last hour with the hip, because those factors are very, very important, and there have been some studies that have demonstrated that. So the quadriceps then creates a force vector as well, and the forces come from the fiber orientation of the muscles. So depending on which part of the quadriceps you're talking about, it's going to be a different orientation or direction of that vector force. So the rectus femoris and the vastus intermedius, I know this is not a very clear picture, but that's pulling more superiorly, vastus lateralis, more to the lateral retinaculum, you've got the VMO and the medial retinaculum. So all of those are kind of tugging on this patella, trying to keep it into the right position. So you have to take into consideration those factors as well. The medial patellofemoral ligament excuse me, merges with the VMO, and it is the primary restrictor for lateral deviation. So that's a very important structure. And when you have a patient that's had a dislocation or luxation of the patella, they can often damage or injure or tear that medial patellofemoral ligament. So it's important to make sure that we keep that
healthy, and keep that in mind as we're rehabbing them. The medial patellofemoral ligament gives more than 50% against the lateral deviation during that initial 20 to 30 degrees of flexion, which, if you remember, is when this joint, or when the patellofemoral joint, is most unstable. As it's starting to move laterally in the trochlea, it's most unstable at that point. So that medial patellofemoral ligament is very important. So we know about the mechanics, but what's the pain coming from? Is it the mechanics? Is it the structures? What's going on? So they have looked at some of these things with different studies. Nobody's come up with a universal, oh, it's this, or it's this, and there's no particular factors or history factors or patterns that they can identify. However, they have been able to identify that there are a lot of free nerve endings that are high concentration in the quadricep and patellar tendon, as well as the retinacula. So if those are structures that are really responsible for moving the patella around or trying to stabilize the patella, if there is abnormal movement, those could definitely respond with increased pain. There's also a chemical reaction or chemical etiology for pain. Substance P increases the sensitivity of the pain receptors, and there's more substance P fibers in the retinacula, in the synovium, in the fat pad, and that triggers a whole inflammatory cascade, which of course is a source of pain. Hyaline cartilage, which is on the surface of both the trochlea, the posterior aspect of the patella, that has no nerve endings. However, subchondral bone does. And if you get chondromalacia, or that softening of that patellar cartilage, that does trigger this chemical synovitis. So which comes first, the cart or the horse, right? Does the chemical issue then trigger development of the chondromalacia? Is it the mechanical factors that contribute? I suspect, as most of us probably do in this room, it's a combination of all of these things, which again gets back to the recipe. The subchondral bone surface is, not cartilage surface, bone surface is very rich in nerve endings. It's very sensitive. Anybody who's broken a bone knows that, right? Increased bone pressure can also develop a process of increased bone remodeling. And if that's that repetitive micro trauma, if you will, over time, can be a constant source of pain generating. There's been a recent study that demonstrated dysfunction in the afferent nerve pathways, meaning the signaling pathways from the knee joint back to the brain to control pain response in patients with unilateral patellofemoral pain. So maybe there is something about how their nerves work in those patients that have patellofemoral knee pain that make them more susceptible to these mechanical forces. And again, no phenotype, meaning no, it wasn't, blondes or brunettes or redheads, at a certain age. There was no pattern that could be identified that you could say, oh, these are the things that are going to make the pain worse, or these are the types of patients that are going to have more difficult problems. There were no signs or symptoms that you could collect or collaborate on that would identify who was going to have the most difficulty with the pain. So what are the risk factors? I think overload and overuse. We all know that this starts about, 2-3 weeks into a season. They're running more, they're jumping more, basketball particularly, sometimes track season because of high jump and hurdles. They're getting worse because they're just loading more. And not one of them has done any preparation, right, before they end up into their season. I think it also, in my practice anyway, and many of you probably have a similar experience, if there's a fall, a trauma, that they, tripped and fell and hit their knee, that forceful compression of the patella, I think can sometimes trigger development of these symptoms. So sometimes it's truly post-traumatic. That doesn't mean they don't have other factors, but sometimes that's the inciting event. There are studies out there that indicate that there's altered VMO and vastus lateralis response time where the VMO fired earlier than the vastus lateralis in control group, control group meaning the non-pain group with patellofemoral pain, creating earlier activation of that medial force vector. And that's kind of, I think, what we all suspect clinically. Can we get that VMO strong enough, first of all? But I think equally important is the timing. Does it happen? Because if the lateralis or the lateral structures are already pulling it here, it's already shifted. So you've got to get that, even if you've got a strong enough VMO, it's a little too late sometimes. There was functional testing done that showed patellofemoral patients with lower strength capacity, measured by vertical jump, and anterior medial lunge, and step down and balance, and reach, and single leg press. Those folks that had difficulty in these strength and functional movements, which kind of gets back to what Dr. McGinnis was talking about in terms of correct position, correct mechanics. So it does seem that there's a connection with this functional movement in their strength and the correctness of the biomechanics of how they move in development of patellofemoral pain. And of course, general ligament laxity can cause more patellar mobility. Are they one of those really loosey-goosey people? And in that case, of course, there is going to be more motion. So we really have to focus on getting that strength and stability. And in my experience, it needs to come from the hip and pelvis almost first, because it's the kinetic chain. You can't treat one joint without treating the other. The Q angle. And this has been, considered the cause and the horrible problem that creates patellofemoral pain for a long, long time. I mean, when I first started practicing, she told you when I graduated. Oh, she didn't tell you when I graduated. It was a long time ago. It was thought, oh, well, if they have a bad Q angle, then that's going to, affect them. But how many people come in the office, their Q angle's like 30, and they don't have patellofemoral knee pain? Well, why is that? Do they have better strength? Do they have, good control? What's their sport? How much are they jumping? So again, it's multifactorial. Is the Q angle important? Yeah, probably. Is there much we can do about it? Not really. And anatomy's anatomy. So I think it's one of those things to recognize and know that there's an issue there potentially of anatomic alignment, but you can't change it. But I think you can do things to try to control the other structures around it. Again, control that kinetic chain through movement so that this Q angle becomes less of a factor. And I think more recently, people have been kind of considering it in that way. Yeah, it's there, it's a problem maybe, but, again, what are we going to do about it? But, 20, 30 years ago, they used to do reconstructive procedures, realignment procedures, breaking limbs to straighten them out. When I did I was still in medical school. There were still hospitals that, if kids had abnormal femoral inversion, they were doing surgical reconstruction, Now, most of the time this was in patients that had a lot of other developmental issues. But nevertheless, that was not all that long ago, still considered to be a reasonable practice. I don't think we're doing much of that anymore, if at all, except in the most extreme of circumstances. So Q angle, something to notice, something to look at, but I don't think it's a definitive factor. Foot abnormalities. We have our foot and ankle surgeon. Absolutely what happens at the foot, right, affects what happens up the kinetic chain. Is that the only issue? And I say this to people, they'll come into the office, oh, well, will they pronate? Well, okay, that's probably a factor, but that's not the only issue going on here. I think you have to look at that. And one of the most important things I've learned clinically, get the patient to stand up in front of you without shoes and socks on, with shorts on, so you can see everything and how are they lined up. So what are the factors that you're dealing with? Do we need to consider putting them into an orthotic? Do we need to develop some kind of strengthening? How tight is their Achilles? How does that affect their foot mechanics? And then, of course, their running mechanics. What do they have in terms of, they have a valgus deformity along the tibia? Is it a varus deformity? Gastroc tightness certainly can limit dorsiflexion and creates more subtalar pronation, which then increases mechanically the Q angle. How that plays into specifically patellofemoral pain, we don't know for sure, but I have to think that it's a factor. Again, is it the whole thing? Is it just one of the spices in the recipe? Probably. There have also been studies that have identified a cavus foot as producing increased forces on the patellofemoral joint with running. And I think most of us know if they have a very cavous foot and it's not properly supported, they are going to, when they're running, probably pronate more and not be properly supported. So that could be, again, a factor. Is it something I'm going to look at someone standing there and say, oh, well, you need to go promptly and get, a custom orthotic? Not necessarily, but it's something I'm going to note in my record and say, I want to look at this later on as we work on some of these other things to see, do I need to address that as a potential risk factor, an issue for this particular patient. So we have the tightness issue, and hamstrings, the patellofemoral joint forces are increased by slight knee flexion or more quadricep forces to overcome hamstring resistance. So the tighter the hamstring is, the harder that patellofemoral joint has to work.